Okay, sir, we are live. You can begin.
Good evening, everyone. Welcome to this Oculoplasty session of MIOC 2020. And we have an interesting session. We have talks on orbital surgeries, lid malignancies, lid reconstruction, orbital imaging, and orbital foreign body. At the outset, I would like to extend my uh, greetings, as well as I wish them in advance Happy New Year. And I also want to express my thankfulness to them, because at the short notice, every one of you accepted this invitation, and from your busy schedule, you took the time and you are attending this session. And on behalf of organizing committee, we are really thankful to you. Now, the first topic is about lid malignancy, and Dr. Savri Desai is going to present this topic. Dr. Savri did his MBBS from Topiwala National Medical College and MS from KM Hospital, and she was a gold medalist. She did her oculoplasty training from LV Prasad Eye Institute, Hyderabad, and currently she is working as a consultant at PD Hinduja Hospital, Mumbai, and also she is attached to Total Eye Clinic. In past, she also worked in Tata Memorial Eye Hospital, Mumbai. She was organizing secretary of Oculoplasty conference in Mumbai, which had a first time live telecast of oculoplasty surgery. She's also winner of AAO award and AIOS award, and she has presented many national and presented in national and international conferences. And I invite Dr. Savri to give her talk. You can share your screen now, Dr.
Yeah,
Savri.
thank you so much, Dr. Milind, and it's a pleasure to be here. I'd like to also thank the MIOC team for inviting me. Just would like to say that, not to make Dr. Milind sound very old, but Dr. Suryavanshi had actually was our teacher when we were residents, and so it's a really good thing to do this talk with you. So I've got a large topic which I'm going to try and cover in a short time. I'll just share my screen. Dr. Milind, please let me know about 2-3 minutes prior in case I overshoot the time.
Sure.
Thank you.
We can see your slides now.
Yes. So I will be covering eyelid tumors, which is a rather large topic. Just one minute, I'm going to minimize. Yeah. So eyelid tumors, when you talk about eyelid tumors, we come to the classification, and just a broad overview of how eyelid tumors are classified. It can be classified based on tissue or cell of origin. So we have epidermal tumors, we have adnexal tumors, and we have stromal tumors. Commonly, what we see is, especially in the general practice, is non-melanocytic, melanocytic, and sebaceous gland tumors. Some of the others which commonly seen are vascular tumors. Further, other tumors which come to us are secondary tumors, commonly seen from the sinuses, metastatic tumors, or it can be classified as benign and malignant. Just a word of introduction here that there was this group of over a 10-year group where they took a lot of consultants who were oculoplasty, oculo-oncology doctors, and they came up with the revised classification, especially for eyelid carcinomas. And they classified it, a little more specifically involving even TNM, which used to not be there in the previous classification. And this is something for people who are doing it, in a very detailed manner. But it's nice to know that this classifications exist and it's easily available on the net. Just to give you a broad overview to classify it with what is done globally, and it's kind of divided into 4 stages based on the type of treatment you give and how extensive the tumor is. When we talk about eyelid tumors, we basically talk about, just eyelid is a structure which is so visible that you can just, see it and identify it. But when you're teaching residents, we just say that this is kind of the laundry list that you should look at, the structures you should look at, because a tumor may appear like this, which looks like a lesion or a lesion, then it can be as deceptive and turn out to be something as large as this. So when you look at eyelid lesions or tumors, what are the things that are called the red flags? The red flags are anything which rapidly grows, which is suggestive of a possible malignant tumor, secondary infection. The color is important. Some can be yellow, blue, red. Also something as feeder vessels, as you can see in this eyelid, superficial eyelid tumor here, which is a vascular tumor. And the other things that you look for is notching of the eyelid, loss of lashes of the eyelid, ulceration of the eyelid, and even something called as skip lesions. We also look at effacement or destruction of the lid margins. These are all called as red flags for eyelid tumors. A broad classification for management is if it's a very large tumor and you need a lot of eyelid shearing procedures or flaps or grafts, a simple thing is to do an incisional biopsy. Or if you can and you're very sure, you can go ahead with an excisional biopsy with a reconstruction. And tumors which are extending extensively into the orbit may need exenteration. These can be associated with adjuvant treatments. Most eyelid tumors do have excellent results and do not have a recurrence rate of less than 4 to 5%, especially if they have been removed well with clear margins using possibly frozen section and a good pathologist. So coming to something that's really common is the non-melanocytic tumor. So I think most of us see this. They can be small, they can be multiple papillomas, they can be, commonly can be sessile or pedunculated. They are even pigmented as is commonly seen. Treatment usually is, if it is cosmetically upsetting to the patient, then you can have an excision, but you can use a cautery. But another thing that works really well is if you don't want recurrences, to use cryotherapy. For marginal tumors, you would want to consider, having a pentagon excision, especially something like this, which if you shave off may give a very bad notching or scarring. So you can shave them off with a cautery or even do a pentagon excision. These are commonly seen and can be excised, even some things such as periocular ones, such as brows. Now coming to pre-malignant tumors, some of these are actual tumors, while some of these are pre-malignant lesions. These are the actual pre-malignant lesions, and they are known as seborrheic keratosis and keratoacanthomas, commonly seen in middle age. These are, kind of sessile and pedunculated, more pedunculated, have a very crust formation on top and can be excised. The important thing about this is that if you have multiple of these, it's known as a sign of lacetrelite, commonly seen in immunosuppressed patients. And these are pre-malignant lesions which can become malignant, so you need to keep a watch for these. Keratoacanthomas are now considered variant of squamous cell carcinomas, and hence you need to document these. They can be easily excised, but you do need to pathologically review them since they have the potential to become an SCC. Both of these are treatable and do not have a recurrence, but need to be observed and documented. Even another feature of keratoacanthoma we will come to later. Coming to your common malignant tumors is basal cell carcinomas, which is one of the common non-pigmented tumors. I mean, melanocytic tumors. However, you will see some patients which have pigment, and so commonly what you see is and squamous cell carcinomas, which is the second common malignancy. Now, both of them appear very similar and do have a kind of ulcerated lesion, but we'll come to those features a little later. So you have some disease associations. So xeroderma pigmentosa is a hereditary disease where there is a fault in the repair of the skin cells at a DNA level, which causes multiple SCCs and BCCs. So these are patients who have recurrent and multiple SCCs, and then you continuously need to keep on removing them. Similarly, basal cell carcinoma also is associated by, it's a syndrome where you have multiple basal cell carcinomas which are present throughout the body. And these are some things you need to document. So when a patient comes with an eyelid or you see another one which looks suspicious, it is important to ask them if they have anywhere else on the body. Coming to keratoacanthoma, which we were speaking about, multiple keratoacanthomas are known as associated with the syndrome known as Neo-Trio syndrome. But the important thing to note is that they could be associated with a type of internal malignancy. Basal cell carcinomas commonly are, they initially start a little pinkish, then they can be nodular or nodular ulcerative. And as seen as this, they will have a rolled over edge. They will have a central crater with ulceration and even telangiectasias on the margins. This is another variety which is very deceptive. It's an infiltrating basal cell carcinoma, which you can almost see so deceptive that it may look just as if there's been a loss of flashes. And these are especially aggressive and need to be sort of reviewed and monitored. You can also have nodular, the nodular ulcerative variety, which is pigmented. Squamous cell carcinomas also have ulceration, but what you will see is that they have these pearly, irregular borders. And the main thing is that they will have keratin, which is kind of the pathognomic feature of the squamous cell carcinomas. Management is similar to what we discussed. Here are just a few examples. So very large tumors such as these, where you are planning a reconstruction, it's a good idea to do an incisional biopsy. In cases where there are lesions such as this gentleman had, he had a lesion which would look normal, skin which looked normal. So we did an incisional biopsy of a small one from the main lesion and this, and both turned out to be basal cell carcinomas. And this is something which you could do an incisional biopsy and then plan. So here is a patient with a lower eyelid basal cell carcinoma with a periosteal flap and a rotational flap from the eyelid, and you get a good resolution. Similarly, you can do for upper eyelid tried and tested methods such as Cutler beard, which gives excellent results in terms of functional and cosmesis. And in especially deeper lesions where it goes into the orbit, you do need to consider exenteration, in which we do eyelid sparing, where we use the eyelid which is not involved, and it gives better healing, faster healing, and you can even put a prosthesis as soon as 6 weeks. I'm not going to harp too much on this, but some of the malignant lesions which we need to know are the kissing or the split nevus, because it has a potential for malignant transformation. And nevus of Ota, as you know, can be ocular or dermal. And these have a risk of potential to ural melanomas and need to be documented and needs to be seen, especially in the hairline and in the palate regions, to rule out any meningeal melanomas. Eyelid melanomas are not commonly seen with us, but they are rare. However, these again, need to be excised. They're aggressive lesions, and usually we do not see them so commonly. We see conjunctival melanomas, and a complete surgical excision is required. You need to do a lymph node examination and a metastatic workup. Coming to vascular lesions, the most common vascular lesion is capillary hemangiomas, which you can see either superficial, deep, or a combination of both. Commonly, intralesional steroids was the modality of treatment. However, now we started giving oral propanol in the dose of 2 kilograms per body weight, which often have dramatic results even in deep lesions. Commonly, if the patient has a very severe ptosis, we could combine propanol with intralesional steroid therapy. Coming to, and this is just a broad overview of neurofibromas and arteriovenous malformations. Both of these lesions we commonly see in the early decade, but like this lady presented later, and you have to rule out all the features of NF1 or 2 and see the classical features which have a combination of NF1. So in these cases, the reason I'm putting is often is considered like as if there is no hope for these eyelid tumors and that you cannot manage them, especially on a surgical level. So there is a technique called a template technique, in fact, which I learned during my fellowship with Dr. Santosh and Dr. Milind. And we actually did where we did a excision of the eyelid tumor and measured it to the normal side using a template. So measurements from the normal eye are measured here. The excessive tumor is removed and the eyelid is reconstructed, and it gives rather gratifying results. The reason I'm putting this up is because we often get patients who even have localized lesions, which is just involving the eyelid with either NF or AVM, or even where it is a little larger and is segmental, but these can still be treated in terms of the eyelid lesion. Coming to sebaceous gland carcinoma, this is one of the tumors which is commonly seen in Asia. It is an aggressive tumor, commonly seen in older individuals, often mistaken to be chalazions which are repeatedly operated, as is seen in this patient. Had 2 surgeries and turned out to be, finally when it came to us, turned out to be a sebaceous gland carcinoma. It often presents with loss of eyelashes, destruction of the meibomian glands. So sebaceous gland carcinoma does really, really well with a good excision with clear margins, frozen section. So in this case, this lady was operated with an excision of the entire tumor with clear margins. A huge flap was done from the upper tarsal conjunctiva with a rotational eyelid flap. And you can see there is an excellent lining which was taken from the the upper lid conjunctiva, and the margin of the lower lid was created, and it has excellent functional and cosmetic results. But there are certain neuromanagements which can be in the form of neoadjuvant chemotherapy, in which you, if the tumor is too large to excise, you can give, and this is something which was tried by Dr. Santosh, and you can give the chemotherapy for 3 cycles and then excise. I'll just be finishing, Dr. Milind. And all this are some of the results. This is again Dr. Santosh's patients. What this does, it is basically compacts the tumor and then allows us to do excision, so that the amount of excision and reconstruction is not extremely vast. These are some of the adjuvant treatments you need to do for some of the tumors. Radiation in certain cases, especially if you have an orbital spread of squamous cell carcinoma, you may need to do. Perineural invasions you may need to consider. These are some of the new therapies which are there for basal cell carcinomas, especially multiple basal cell carcinomas, and for squamous cell carcinomas. And finally, the take-home message is that we need to be able to identify it early, looking for the danger signals. Most eyelid tumors resolve and have less recurrences with clear margins. Histopathology is a must. I always say that when in doubt, review again, and not to forget some of the mimics and masquerades. Thank you.
Thank you, Dr. Savri. Over to Dr. Said.
Okay, thank you, Dr. Savri, for the wonderful talk. You cover each and every aspect of the eyelid in a very short period of time. Now I invite Dr. Milind Suryavanshi for the eyelid reconstruction technique. Dr. Milind has done his undergraduation and post-graduation from the Government Medical College Miraj. He did his FRCS from Royal College of Glasgow. Dr. Milind did his Oculoplasty fellowship from Regional Hospital Chennai. He has also worked as a professor in India and is currently working as an anti-segment and oculoplastic surgeon and in charge of Oculoplasty Unit at Armed Forces Hospital, Muscat, Oman. He has many publications and presentations to his credit. Dr. Milind, please.
Thank you, Dr. Said. In today's presentation, I'm going to talk about lid reconstruction, its indications and options. The goal of lid reconstruction is to provide adequate lid function, to afford globe protection, to achieve acceptable aesthetic results, prevention of tear film evaporation, and unobstructed visual field after the surgery. The indications are congenital and acquired. In congenital indications, it could be isolated coloboma, or it could be associated with syndromes like Golden Harvest syndrome, Teacher's Collins syndrome, Fraser syndrome, etc. In acquired causes, it could be surgical resection of tumor, trauma, burns, irradiation, and previous complicated surgery. These are the few examples. This child was seen by me for lid coloboma. This is the example of a traumatic lid loss. There is a lateral 1/3 of lower lid loss. This is the patient of sebaceous gland tumor, and after excision of the tumor, he lost almost whole of his lid. This is the complicated surgery done at some other center and was referred to me. When patient comes to you, you have to evaluate the lid defect. The lid defect could be full thickness or partial thickness. The lid margin could be involved, or it may be spared. The size of the defect has to be measured. The location is also important. It could be medial, lateral, or central. The canthal tendon involvement has to be taken into consideration. The age of the patient is also important, because laxity of the tissue in elderly people helps in reconstruction. The condition of opposite eye, contralateral lid, and mobility of the surrounding tissue is also evaluated. Now we'll talk about partial thickness defects. The partial thickness defects of anterior lamina of less than 5 mm can heal by secondary intention. The closure is easy in elderly patient because of the redundant skin tissue. If the incisions are placed, then they are placed in the along the natural creases. The defect more than 50% will need full thickness skin grafting. The anterior lamellar defect could be repaired by primary closure or by the healing by secondary intention, also called as laissez-faire. The skin grafting can also be used in indicated cases. If the flaps are required, then sliding, transpositional, advancement, rotational, and island flaps are used. Now, these are the few examples. This was a Omani patient, came with a fish hook injury. And you know that fish hook is a very notorious that it nibbles the tissue. And this is the post-operative picture. This again, a Omani officer, military officer, he had a wound which was infected and it was healed by secondary intention. Now in this patient, skin graft was used. He had a road traffic accident and when the scar was excised, he had a large defect. The full thickness skin graft was taken from the skin behind the pinna and it was grafted. Now this is an interesting case. This lady had an acid burn. Her husband threw acid on her face and she had a large scar. When it was excised, she had a large defect and the rotational pedicle graft was used to reconstruct the lower lid. Now we'll come to full thickness defects. If the defects are small, ranging between 25 to 50%, the primary closure is enough most of the time. For medium defects, between 50 to 75%, tensile flap is used. For large defects, more than 75%, for lower lid, either mustardase cheek rotation flap or huge flap is used. For upper lid defects, mustardase pedicle flap or Cutler-Beer procedure is used. Now I'll talk about primary repair. The small defects can be reconstructed by direct approximation. The defect is first converted into a pentagon with vertical sides covering the height of the tarsal plate and converging at fornices. If there is some tension, which mainly happens if the defect is about 30 to 50%, then lateral canthotomy or cantholysis is done. Now this patient had a road traffic injury. He came to us last month and he had a loss of 1/3 of his lid. We converted that into a pentagon. This is the immediate post-operative picture and this is after 3 weeks. This is another case who had a loss of tissue, lower lid, 1/3 lower lid was lost at near the lateral canthus. She also had full thickness lid laceration, but there was no tissue loss. And this is the picture after the post-operative repair. Now we'll come to the medium size flaps. The tensile flap is a semicircular flap that can be used for upper as well as lower lid. The defect up to 50% in the middle and the central portion can be corrected. For lower lid, the semicircle is directed upwards, and for upper lid, the semicircle is directed downwards. Now, this is the lower lid defect, and the semicircle has to be directed in upward direction. This is the example of upper lid defect, and the semicircle has to be directed in a downward direction. Now, we'll take the example of upper lid tumor. This was a basal cell carcinoma. involving almost 1/3 to half of the lid, upper lid. The tensile flap was used to close the defect. This is the example of lower lid basal cell carcinoma, and this was repaired by, again, tensile flap. Now we'll come to Mustardase cheek rotation flap. To close the larger defects of lower lid or lid cheek junction, the Mustardase cheek rotation flap is used. It is useful in reconstructing anterior lamella. Now, this is the defect, and this is the dissection made, and this flap is rotated and closed. The defect is closed. This is the, again, Omani patient who had basal cell carcinoma, and almost whole of the lower lid was excised. And this was repaired by the Mustardase cheek rotation flap. This is immediate postoperative period, and this is after a few months. This is another example. This lady was seen by me in India. She had a basal cell carcinoma. Mustardase cheek rotation flap was used. This was immediate during the surgery. This is immediate postoperative period, and this is late postoperative period. The Mustardase lid switch flap, here the full thickness lower lid is transferred with its lid lashes to close the upper lid defect. The pedicle has its own blood supply, and it is divided after 4 to 8 weeks. Unlike Cutler-Beer bridge flap, the vision is not occluded. It is a little difficult technically though. This is the upper lid defect. The lower lid is transferred to repair the defect, and after few weeks, both upper and lower lid are reconstructed. This was a case of sebaceous gland carcinoma, and during the surgery, we had to excise almost whole upper lid. This was repaired by the Mustardase lid switch flap, and these are the post-operative pictures. This is another example where almost the whole of the upper lid was involved. Again, the lid switch flap was used, and this is the post-operative result. Cutler-Beer bridge flap, Savri has already covered, so I will go very fast. This be used to cover the defect almost 90%. The full thickness lower lid tissue is mobilized and pass under the intact bridge of lower lid and sutured to the upper lid. And in second stage, both upper and lower lid are reconstructed. The huge flap also she has covered. This is the tarso-conjunctile flap, where the part of the tarsus with conjunctiva is brought down from the upper lid to close the lower lid defect. The full thickness skin graft or mobilized skin from the anterior forms the anterior lamina. And after 6 to 8 weeks, both the upper lid and lower lid are reconstructed. In summary, the goal of the lid construction is anatomical, functional, and aesthetic restoration of the eyelid. The choice of the procedure is determined by the nature of the defect, age of the patient, availability of the surrounding tissue, and the surgeon's experience. Thank you.
Very nice talk, Dr. Milind. Can you just switch off your sharing, please? So our next speaker is Dr. Milind Naik. And Dr. Milind did his post-graduation training from CMC Vellore. Dr. Milind did his ophthalmic plastic surgery fellowship from LVPI, Hyderabad. And he also underwent ophthalmic and facial plastic surgery fellowship from University of California, LA. Dr. Milind has created a niche for himself in facial aesthetics. Currently, he is a consultant and head of the ophthalmic plastic surgery and facial aesthetic department in Al Prasada Institute, Hyderabad, India. And he's also an adjunct professor of ophthalmology University of Rochester, New York. Dr. Milind has lectured worldwide. Dr. Milind, please.
Thank you, Dr. Saeed, and good evening to all of you. At the outset, I would like to thank Milind Suryavanshi and also Dr. Rashid Saeedi, the organizer, and the entire MIOC team for this session in oculoplasty. And I have very fond memories of the Muscat Ophthalmic Conference in 2018, which was, of course, in person. Things have changed now, but we hope that we would be able to meet each other in person very soon. So my topic is about periocular aesthetics and starting tips for general ophthalmologists. So rather than talking specifics about how to do a particular procedure, this talk is more philosophical about how to change yourself from functional to an aesthetic practitioner, being an ophthalmologist. So whenever someone is only into cataracts, refraction, and general ophthalmology, when the discussion of aesthetics comes up, these are the three thoughts that come to their mind. Should we be getting into it? Because that is dermatologist's job, plastic surgeon's job. If we do get in, what is the scope? And how do we begin? So I'm just going to address all of these the way I perceive it. Face is an area where multiple specialties dwell. It is ophthalmology, dentistry, ENT, plastic surgery, dermatology. And within these areas, there are niche areas that people develop, like hair transplant, rhinoplasty, and so forth. So it practically belongs to everyone, or the corollary is that it doesn't belong to any single person. So as long as you get the right amount of training and you're primarily within the area that you represent, you are good to go. So if you were to look at the basic statistics, there are only 2 cataracts per person, but there are 4 eyelids and there are multiple wrinkles. So it's obvious that you would want to practice beyond cataracts, and aesthetics is a good branch. And there are rumors and discussions about drugs which could one day dissolve the cataract. So what would you do with all your phaco machines and everything else that you learned all this while? So might as well get into something more exciting. And this is one more reason which always inspires me to motivate others to get into aesthetics. This is the most popular couple, Jean and Alastair Caruthers, the ones who popularized the cosmetic use of Botox. And one of them is an ophthalmologist. So this area really should originated from ophthalmology and should stay within ophthalmology. And finally, I cannot understand why someone who can perform these complex surgeries cannot do injectables and fillers and blepharoplasty. So just to take you through a spectrum, apart from the ones who come to you for cosmetic requests, you would also have your refractive patients. And as soon as their spectacle is gone, they start noticing the periocular issues. And they would obviously want treatment for that. And if you could combine these packages, there's nothing like it. This particular lady who has mild ptosis on the left side, which got missed with the glasses. So should we do it? The answer from my side obviously is yes. Now, what is the scope? The scope.
It's 6:45.
If you want to look at what are the low-hanging fruits, they are obviously the injectables. Botulinum toxin is something which many of us as ophthalmologists are already using it for spasm treatments. And fillers, although not directly, but indirectly, you do deal with viscoelastics every day. And a filler under the skin is the same product. It's hyaluronic acid, which is cross-linked. And learning a little bit on this area can really make you a master in the eyelid region. So this is the primary role of a filler. There's a hollow that you can see underneath the eyes. That is a tear trough deformity. And this is not necessarily an aging change, which can be corrected with a filler injection. And if you are a person who does external DCRs, this is the best training model for you to learn filling. Just use your xylocaine instead of a filler, or even use a viscoelastic and try to fill each tear trough before you take your incision. And that can make you confident. One more reason why we should be into this is because dermatologists are very scared of periocular region because of the reports of blindness. And we are the ones who can really understand the periocular vascular anatomy and inject safely or even identify these side effects sooner. And once you get comfortable in periocular region, you can move on to the mid phase and lower phase for the injectable applications. Or with good training, you can even start offering autologous fat transfer, which is not very difficult. Blepharoplasty is obviously something which is within our field area. The reason why it is still our job is because the transconjunctival approach is very popular among patients and not so popular amongst the general plastic surgeons. So this is an area where we have an advantage, and we should offer what we can do for these patients. Some oculoplastic surgeons venture into lasers by studying the adequate details of it and even buy these. Personally, I prefer not to venture into dermatology to that extent, but it's an option. But obviously, you will have to restrict yourself to the face. Anything major like brow lifts and facelift obviously will need a fellowship training, and you would have had to see a couple of cases and manage them to know how these patients behave post-operatively. So minimal training, Botox and fillers, moderate training, blepharoplasty, and extensive training, you can venture over the entire face. So that's about the scope. The scope is the entire face at the end. How do you begin? So initially you have to begin with a change in your mindset. So you have to get into the world of the people who ask for aesthetic practice. They are not necessarily functional people, and their concerns might sometimes be perceived by you as trivial, but it is not. You have to give equal importance to their findings and concerns. Read about their magazines, what concerns them, what's the latest trends. Social media is a good way to find that out. Also attend non-ophthalmology conferences like multi-speciality or dermatology to know more about what's happening in the aesthetic field. Attend injectable workshops, which are sometimes paid, but it's all well worth the money. So just to summarize, learn aesthetics before you run out. I mean, you have a lot of competition around you. A good training is important, but there are certain areas which you can start off just by minimal training or observing people who do it, that is injectables. And we really are at an advantage here. Thank you.
Thank you, Dr. Milen, for a very apt talk to motivate the general ophthalmologists. Now, Dr. Milen, please.
Yeah.
On the next speaker.
Yeah, thank you, Dr. Naik. It was really wonderful talk, and I'm sure many ophthalmologists would take up the oculoplasty procedures which you described. Our next speaker is Dr. Girish Kukade. Dr. Girish Kukade did his MBBS and MD radiology from BJ Medical College, Pune. He also has FRCS degree. He was working as a senior consultant and head of the department in Armed Forces Hospital, that is our institute. But at present, he is working as head of the radiology department and chief consultant in Burjil Hospital, Muscat. He is the founding member of radiology residency program in Oman. He has several publications, presentations at national and international conferences, and has won multiple awards. He continues to teach young radiologists, preparing them for FRCS examination. I invite Dr. Girish to speak on diagnostic modalities of orbital lesions.
Good evening, everyone. I would like to thank the organizing committee and Dr. Milen for giving me an opportunity to speak about the role of radiology in orbital lesions. This is a brief overview. So I will be talking about various modalities used, the advantages and disadvantages of each, and review a few cases to highlight the features. Has somebody else been forwarding this, Dr. Milind? I don't know how this is happening. Okay, so the main modalities that are used are CT, MRI, and ultrasound, and plain film radiography is not really used any longer. Angiographies and nuclear medicine are used occasionally. So MDCT is the mainstay of the orbital imaging. Abundance of intra-orbital fat provides good soft tissue contrast. It has short scan time, so less sensitive to motion of the globe and eyelids. But its disadvantage is that it has radiation. MRI is used as a problem-solving tool. Okay, it is particularly useful in characterization of masses and delineating spread of infection. It has an excellent soft tissue contrast and tissue characterization, but it's unfortunately sensitive to motion because sequences take longer, and of course it's contraindicated in metallic foreign bodies. Moving on to ultrasound, ophthalmologists use it extensively. It can be used for initial assessment in children, and it's definitely useful whenever ocular media are opaque. It has no radiation and you can do real-time imaging. Plain film radiography, as I said before, is not really used any longer, but we occasionally use it as a screening tool prior to any MRI if there is any suspicion for a metallic foreign body. Coming to DSA, nuclear medicine, PET scan, PET CT, PET MR, I don't know why this is going forward. Just give me 1 second. Okay, I think it's probably using a timer. Okay. So what is the basic approach to the differential diagnosis? You look at the age of the patient, the presentation, chronicity of the lesion, the location as far as compartments are concerned, the precise structure involved, the various imaging features, whether there is any calcification, and of course, if there is any intracranial extension. So we'll just review a few cases. We start with orbital tumors. Some of these lesions show calcification, which are well seen on CT, and majority of the tumors happen to be T2 hyperintense, means white, and T1 hyperintense, except cases which are hypercellular tumors like melanoma and lymphoma. They're T1 hyperintense, so the diagnosis is easy. So this is just a case of one of the nerve sheath tumors, schwannoma. This is the most common tumor seen in adults, and it is MRI is more sensitive. You can see the solid component and the cystic component, and the solid component enhances with contrast. It can also be seen well with CT as well. Moving on to meningioma, it's seen in middle-aged women. Okay, again, calcification is seen in 20 to 50% of cases, as you can see on this CT here, and MR will show you the enhancement, which they enhance brightly. Gliomas of the optic nerve, they're generally again present early in life, and MR is very good at demonstrating the location or confirm the location and its enhancement, and of course it also shows us the intracranial extension well. Melanomas, as I mentioned before, are T1 hyperintense, and we can see here it is T1 hyperintense and it enhances with contrast. And on PET scan, we can see that they show increased uptake. Metastasis can be virtually from anywhere, technically, but if the metastases are from breast and stomach, and if they are serous, they can cause inophthalmos. And we should also look for simultaneous brain metastasis, which makes the diagnosis easy. Moving on to retinoblastoma, seen in young people, CT is the modality of choice. Majority of them show calcification, and they do enhance with contrast. There are some tumor-like conditions like cavernous hemangioma in adults, which show progressive centripetal enhancement. As you can see here, it is enhancing. And the capillary hemangiomas on MR, they can show the flow whites. So that will tell you that there are some vessels within. Varix is a very peculiar entity. When I've seen a few cases, I mean, you see one or more dilated veins. But interesting thing is that once you tell the patient to do Valsalva maneuver, they distend heavily. So this is a very peculiar entity. And of course, there are angiomatous malformations or arteriovenous malformations, which can be shown with CT angiogram, MR angiogram, or even a DSA. There are venolymphatic malformations, which are not strictly tumors, but Their peculiarity is that they can be multilobulated, they can show fluid levels, they can have proteinaceous and hemorrhagic components. And the only thing is that they don't distend with Valsalva maneuver, unlike varix. Coming on to carotid cavernous fistula, I mean, these we can see a dilated superior ophthalmic vein, and angiogram shows a reversal of the flow in the superior ophthalmic vein. So these patients present with pulsatile exophthalmos. Moving on to orbital infections, I mean, whenever it is a post-septal infection, these are most commonly cyanogenic in origin, and we can see the inflammation, abscess, and various complications. So what are the imaging markers? Basically, asymmetric soft tissues, dirty fat, fat standing, which is shown well by CT as well as MR, loss of soft tissue planes, collections outside, whether subperiosteal or within the orbit, air in the soft tissues, and changes in the bone. So there is basically a Chandler's classification, and it has 5 types. But what is probably the most important is to know whether the infection is limited anterior to the septum or it is expanded posteriorly, which basically involves the wall of the can potentially involve the wall of the orbit. So that differentiation is important. So a few cases of orbital infection, we can see actually there is bilateral fat standing, that is a dirty fat here, and the patient had sinusitis. Here we see, apart from the frontal sinusitis, we have prefrontal swelling, that is also called as spots puffy tumor, and we have a small pus collection inside. This is basically an empyema with enhancing membrane. And sometimes cases are quite obvious, like we have a large intraorbital abscess with the fluid level and intracranial extension. Sometimes with infections, we can get venous thrombosis, and this is a good case to show that there is superior ophthalmic vein thrombosis. And if you look at the cavernous sinuses, this area is supposed to enhance nicely with contrast, but you can see that it is hypointense. So that means there is thrombosis. Moving on to orbital inflammatory diseases, is the thyroid orbitopathy. The difference between that and the pseudotumor is that thyroid orbitopathy spares the tendon. It's seen in Graves' disease, but can also be seen in euthyroid and hypothyroid patients. And we can see that the muscles are thickened in both orbits, but it can be a single muscle as well. Moving on to pseudotumor, these will tend to include the tendon as well. So you can see that there is thickening of the tendon. Apart from muscle belly, the tendon also is thickened. There are other inflammatory conditions like sarcoid and vagus, which also are inflammatory disorders and show enhancement. You can see some enhancement of the dura in the vagus. The patients can, when there is orbital apex disorders or inflammation, they can present with Tolosa-Hunt syndrome. It's a painful ophthalmoplegia, and what we see is that there is abnormal enhancement. So there is a alteration in the normal appearance, and there is fat standing, as you can see here, and it shows diffuse enhancement. Just a few lacrimal gland lesions, they can be benign or malignant. We start with benign lesions, so pleomorphic adenomas, you can see beautiful enhancement here. They are in the location of the lacrimal gland. That's an indicator that they're probably originating from lacrimal gland. Solitary fibrous tumors also are seen as enhancing with contrast. The malignant lesions, the common one is adenoid cystic carcinoma, and it's very difficult to differentiate it from other conditions like dacryoadenitis adenoma or lymphoma on imaging alone. Lymphoma is a bit peculiar in that it's a hypercellular tumor, less water in it, so it shows diffusion restriction. So what happens is on B1000 images, we can see that it is hyperintense, and on ADC map, these are hypointense. So this is suggestive of diffusion restriction, and this is commonly observed in lymphomas. They also enhance beautifully. MDCT is a modality of choice in trauma. Again, we don't do plain films any longer. Sorry for that. And there is always a checklist of things to look for, like foreign body fractures, globe injury, etc. So the 3D reconstruction can show us the fractures beautifully, as in this case. In the past, we used to talk about teardrop sign as a possible herniation of orbital contents, but these days with MDCT, we can see this very elegantly with distortion or entrapment of the muscles. Moving on to foreign bodies, the metallic and glass foreign bodies are well seen, whereas wooden or organic matter foreign bodies are seen as air density or low attenuation density. As you can see here, this is a wooden foreign body. There are a few congenital disorders which are presented like masses, and so this is a dermoid which is seen as hypodense on CT, and on T1-weighted imaging, fat is bright on MR, and whenever you do fat suppression, it loses signal. So this is consistent with the dermoid. Sorry for that. Optic neuritis is a part of orbit, so I just thought I'll mention it, that it shows increase in the thickness of the optic nerve, its enhancement, and of course sometimes you'll have to do other imaging to look for lesions elsewhere in the brain or the cord. The ophthalmologists see it regularly. The retinal and choroidal detachment are well shown by ultrasound, and they can be seen on CT as well as MR. And there are few osseous lesions for which CT is extremely helpful. For example, here we have a ground glass matrix, and this is consistent with fibrous dysplasia. You can at times have to image other anatomical structures to know the reason. For example, in this case, the etiology of this enhancing lesion was not clear, and when there was a search for primary cholangiocarcinoma of the liver was found. So my take-home message will be that imaging plays a vital role in the diagnosis. CT is the mainstay of diagnosis in tumors, infections, foreign bodies, and trauma. MRI is complementary and a problem-solving tool due to its superior soft tissue contrast and tissue characterization. It also can be done for tumors, tumor-like conditions, and infection as needed. It's a modality of choice whenever you want to look at the nerves and their or in intracranial extensions. Ultrasound is often used as first-line screening, especially when there are opaque media and in children because of risk of radiation. So I thank you for your attention.
Thank you, Dr. Girish. I'm sure many ophthalmologists will look at the CT and MRI images now and will have at least some orientation. Over to you, Dr. Said.
Okay. Now invite Dr. Santosh Navar, who needs no introduction. Dr. Santosh is a renowned ocular oncologist and oculoplasty surgeon known internationally. Dr. Santosh did his postgraduate training in ophthalmology, followed by a senior residency in ophthalmic plastic surgery at the prestigious RP Center of Ophthalmic Sciences, All India Institute of Medical Sciences, New Delhi. He did his fellowship in ocular oncology at the Wills Eye Hospital, Philadelphia. He was also a fellow of American College of Surgeons and lately honored with prestigious FRC Opt, London. He is a recipient of many awards, which include prestigious Shanti Sadhu Bhatnagar Award from Government of India, and recently has been honored with Senior Achievement Award by American Academy of Ophthalmology. He is currently Director of Medical Services, Director Department of Ocular Oncology and Oculoplasty at Center for Sight, Hyderabad, and is also a Director of National Retinoblastoma Foundation. He has spoken practically in every oculoplasty conference worldwide. Over to you, Dr. Santosh. Welcome.
Thank you so much, Syed, and thanks, Milind, for the kind invitation. It's a pleasure to be here and speaking to your society members. I'll be sharing my screen. Is it visible?
Yes.
Yeah.
Okay. So I'll talk about minimally invasive surgical approaches to the orbit. It is very elegantly said that less is more. Actually, in design, minimalism is something that that stands out as extremely elegant, and that does not false about surgical procedures as well. But whenever you consider orbit and orbital tumors, you have to understand that 50% of orbital tumors happen to be malignant tumors. So you have to have an oncological overview to optimize eye salvage, life salvage, and vision salvage. So prioritization is always for life salvage, followed by eye and vision salvage. Whenever we have a patient with orbital tumor, we go by logic, a good clinical history, regional and systemic evaluation, and imaging, as was very nicely pointed out by Dr. Girish Kukade, followed by specific investigation, and then comes surgery. So surgery is not that something that we would jump to at the outset. We go through this systematic evaluation of the patient before we even consider surgery. And before we even consider surgery, we have to answer all these questions to ourselves. What is it likely to be? Is it a benign or a malignant tumor? Where is it likely to be located? Intraconal, extraconal? Is it diffuse? Does it have paranasal sinus extension? Does it have intracranial extension? Is it related to any of the extraocular muscles or optic nerve? Is it operable? Do I just do an incisional biopsy, or would I completely excise it? So when you go through this process, you have a very clear paths to make decision. There are certain cases where you would say a clear no to surgery. There are specific instances where you would say absolute yes to surgery. And there are some gray zones where you may or may not do surgery depending on your experience and what you're thinking. For example, a patient with bilateral proptosis with temporal fossa fullness, a clear case of metastatic Wilms, you wouldn't do surgery in this patient. Exactly similar case with raccoonized and periocular hemorrhage, metastatic neuroblastoma, where no surgery is performed at least until a diagnosis is required by the pediatric oncologist, where you might want to do just an FNAC or a small biopsy. If a child were to come to you with subconjunctival hemorrhage and also proptosis, you think of granulocytic sarcoma, and the only intervention that you would do is a peripheral blood smear to confirm the diagnosis. Whereas minimal intervention would be in the form of a fine needle aspiration cytology in a patient who has an osteolytic soft tissue lesion in the supratemporal orbit centered in the sphenoid wing with a prior history of multiple myeloma, just to diagnose that it is indeed plasmacytoma before you shift this patient for care by an oncologist. That is how this patient was diagnosed by a simple fine needle aspiration cytology. Now, there are non-surgical approaches as well. Like this patient who has very minimal proptosis of the eye, you can't even notice that he has subtle proptosis of the right eye. But what he has is an orbital apical tumor, which on MRI is clearly a cavernous hemangioma. But its location is very precarious. It is sitting right at the superior orbital fissure, abutting into the superior orbital fissure, and is displacing the optic nerve and compressing it, resulting in visual field defect. And the patient happens to be an airline pilot, where his function of the eye, that is vision, and absence of diplopia following surgery are extremely important for him to continue his occupation. Surgery is possible, but surgery can have complications such as reduction of vision and diplopia. So in this situation, we opted for stereotactic radiation. And this is what happened. The tumor reduced to about 30% of its initial volume, and the visual field defect completely reversed. So this is almost like a non-surgical approach. You don't even need a histopath diagnosis because MRI was very characteristic. This is exactly a similar case from the literature, where they did gamma knife irradiation of 2000 centigrade for a similar tumor, much smaller, but with much profound visual field defect, which fortunately returned to normal following gamma knife irradiation. This is a published case. So the current dictum is that if you have a tumor which is in the shape of a pear, which is impinging in the superior orbital fissure area and abutting against the optic nerve, and if you know the diagnosis already, you may not want to do surgery and consider alternative modalities. Then comes minimal interventional procedure, that is injection. Like this young lady who has subtle proptosis of the right eye because of a lymphangioma, which is very diffuse. It's all around the medial rectus, superior rectus, LPS complex, lateral rectus, and it's surrounding the optic nerve. Now, if you want to debulk it, of course, you can go supratemporally or transconjunctivally from the medial side. But then the risk of complication is quite high because it's a diffuse lesion. So there we bring in injection, either picibanil or bleomycin, injected 1 to 3 times. Mean number of injections that we generally need are 2 injections, and the tumor completely settles down. It may shrink, incompletely resolve, or completely resolve. As in this patient, we had complete resolution. You can see the intracorneal component completely resolved. You can also see on the coronal sections that the eyeball has gone back from being proptosed earlier, and the patient has got the cosmesis that she wanted. So this is by picibanil injection, and we can actually have exactly similar results with intralesional bleomycin. This is a child with a chocolate cyst, that is a secondary hemorrhage within microcystic lymphangioma, which was aspirated. This is the amount of blood that we got, and we injected an equal amount of bleomycin. Currently, I inject about half the amount of the aspirate, about 50%, and that still works. This is one more patient with lymphangioma treated with bleomycin, and one more similar case. So bleomycin works equally well, and other drugs are, of course, doxycycline, which can be injected, and TCGLU has also been used in the management of macrocystic and microcystic lymphangioma. One more similar situation where an anterior lymphangioma was injected with bleomycin, and it worked very well. This is again an anterior lymphangioma, settled down very nicely with injection, bleomycin. So minimal interventional procedure here is intralesional injection. And it's been described that even in dermoids, we can aspirate if the contents are not very putty-like or tenacious. We can aspirate a dermoid and inject within it sodium tetradecyl sulfate, which is called foam sclerotherapy for dermoid, which cannot be excised without a lot of scarring or intervention. Now, this is a child who has a lesion which is osteolytic, and it is at the orbital roof, and the dura is minimally involved. If you were to curate it, then you would obviously have implications in terms of CSF leak, etc. We knew, clinically, we knew that it was possibly an eosinophilic granuloma because the child had had a pathological fracture of a long bone earlier. So that information we had. But then curettage is the treatment of choice for eosinophilic granuloma standard. Here we proceeded with a safe biopsy from the middle of the lesion, confirmed that it was indeed eosinophilic granuloma intraoperatively, and injected it with dexamethasone, intralesional dexamethasone under visualization, and you can see complete remodeling of the bone. This is 3 months later, partial remodeling, and after about 6 months, there is complete remodeling of the bone. This child did not need any major surgical procedure. Exactly similar situation with breach of the roof of the orbit, eosinophilic granuloma, injected with dexamethasone, and it completely settled down. So steroid injection is one of the treatments for eosinophilic granuloma. Now, when we go to excisional biopsy, when a tumor is either it is benign or malignant, but it is well circumscribed, non-infiltrative, not associated with crucial structures such as extraocular muscles or optic nerve, and is unlikely to have functional deficit, then you want to completely excise it. There are surgical procedures which range from neurosurgical, endonasal, orbital, transcutaneous, with or without bone cut, all that. But minimal interventional procedure would be a transconjunctival approach. Transconjunctival approach is very versatile because you can make an incision right here at the medial canthal area, transcaruncular incision or transplica incision, extend it inferiorly along the inferior fornix, do a lateral canthotomy and inferior cantholysis, and also extend this conjunctival incision right up to the palpebral lobe of the lacrimal gland, right under it. So we have about 75% of the orbit accessible to us by transconjunctival approach. So you can use it for a medially located tumor, infranasally located tumor, inferior lesion, infratemporal lesion, and even for a supratemporal lesion, both intraconal and extraconal. So we have about 75% of the orbit accessible to us by transconjunctival incision. Now let's just look at a couple of case examples. This is a child with orbital teratoma, a rapidly growing lesion, which was on both the sides of the optic nerve. This is a fully grown tooth within it, confirming the diagnosis clinico-radiologically. We approached it with a transconjunctival incision with a lateral canthotomy and inferior cantholysis. Look at the visualization. This is the cystic component of the lesion on the lateral side, and this is the optic nerve. We could actually see it under microscope. That is the solid medial component, and the lesion could be completely excised. This is the groove through which optic nerve was passing. So we could spare the optic nerve and its function and yet excise the lesion by this panoramic view that was possible, and the child did well. Of course, he has squint that needs to be corrected. This is about a 40-ish lady who had an intraconal lesion. She's a professional and wanted a very quick recovery. We knew that it was cavernous hemangioma and approached it by a transconjunctival approach, inferior transconjunctival approach. I'll just show a video. This is a standard approach even for orbital fracture repair and also for thyroid decompression of the floor and lateral wall. This is a lateral canthotomy and a small inferior cantholysis. This will give us ready access to the inferior fornix, and we make an inferior fornicial incision, not right at the inferior fornix, but about 4 millimeter from the lower edge of the tarsus. That's a RF electrode that's being used, and the tissues are retracted to reach the area of interest, which is the inferior orbital margin. Then we make an incision in the soft tissue around the inferior orbital margin and a periosteal incision very close to the inferior orbital margin and reflect the periosteum. You can even go transarcus, you can go transeptal, you can go transperiosteal. There are 3 approaches that are possible once you make an inferior fornicial incision. This is the periorbita being reflected off, And the end point of periorbital dissection is the visualization of the apex of the inferior orbital fissure or the infraorbital nerve. You don't want to disturb either of these structures. Then you cauterize to make sure that there is no irritating bleeding. Then you go ahead and make an incision in the periorbita in the quadrant where the tumor is located. This tumor was located slightly on the temporal side, temporal to the optic nerve, infratemporal to the optic nerve. And then we expose the tumor using blunt dissectors, visualize it, dissect it about 3/4 or 2/3, and then apply a cryoprobe for a good hold over the tumor and an anteroposterior traction, and gently wriggle the tumor out. And as it comes out, we have to look for a feeder vessel at the posterior aspect of the lesion. And if you see one, as we did here, we have to cauterize it so that there is no secondary bleeding that is possible. Then ensure hemostasis. And all you need to close here is the lateral canthal incision that we had made so that the lady gets a nice pointed lateral canthus as is normal and anatomical, and put in a few sutures through the inferior fornacial incision. These could be buried vicryl sutures, 4 or 5 sutures with little space that is left for egress for any secondary hemorrhage to come out. And these patients do very well postoperatively. There's the same lady after about 10 days without any stigma of orbital surgery. And there are other patients also. This is a child with a cavernous hemangioma removed exactly similarly. There's an elderly lady with a neurolemoma of the infraorbital nerve with intraconal extension with an inferior fornacial approach. There's a fibrous histiocytoma with inferior fornacial approach. Now, when we talk about lateral orbitotomy, we resort to non-bone cut lateral orbitotomy, even for major lesions such as adenoid cystic carcinoma of the lacrimal gland. This patient has been chemo-reduced. You can see a defect in the bone there, a notch there, which is very well visualized. Even here, we want to do a non-bone cut lateral orbitotomy because we want to be minimally interventional. And in adenoid cystic carcinoma, again, if you cut the bone, there is always a possibility of microscopic tumor deposits within the bone if the capsule of the tumor is interrupted. So that's an en bloc excision. We're localizing the periosteal adhesion to the tumor. And then we make vertical cuts in the periorbita like that on both the sides of the tumor, dissect it free from the adhesions that it has, because malignant tumors are infiltrative and are bound to have adhesions. So leave enough tissue on top of the tumor so that we can hold it, not directly holding the tumor. And then apply a cryoprobe for a dissection under visualization without cutting any crucial structure. And there the tumor comes out without any bone cut at all. So this is the young lady who had adenoid cystic carcinoma who did well following excision. So in conclusion, I would say that minimally interventional approaches, which are of course well planned in the orbit, can help reduce the time of duration of the surgery, reduce the morbidity of the surgery, and also optimize outcome without undue complications. Thank you so much.
Dr. Milan, unmute your mic.
Sir, you're on mute.
Thank you, Dr.
Unmute.
Santosh. It was excellent presentation and beautiful demonstrations of the surgical skills. Now, the next speaker is Dr. Said Rizvi. Dr. Said Rizvi has done his MBBS and MS from Jain Medical College, Aligarh, and he was a professor in that institution in the Department of Ophthalmology. Presently, he is consultant and head of the Oculoplasty and Ocular Oncology Services, the Department of Ophthalmology, Al Nahda Hospital, Ministry of Health. Dr. Said did his oculoplasty training in Helsinki University Central Hospital, Finland. Dr. Said has many publications and presentation to his credit in national and international conferences. May I invite Dr. Said now?
Thank you. Thank you, Dr. Milan, for the introduction. At the outset, I would like to thank Dr. Rashid Al-Saidi and MIOC team for giving me this opportunity. I'll be talking on intraorbital foreign bodies. I have no financial disclosures. Intraorbital foreign bodies can be purely orbital or transorbital with involvement of paranasal sinuses or intracranial cavity. They can be further classified as inorganic or organic depending on the material they are made up of. Orbital foreign bodies often present with diverse clinical problems, creating confusion among the ophthalmologists. Though penetrating injuries of the orbit are usually obvious, however, cases of retained intraorbital foreign bodies after even a minor trauma are still continue to be missed. So these missed intraorbital foreign bodies can lead to sight-threatening complication as well as other ocular complications. So in the next few slides, I will be dealing with a few interesting cases of intraorbital foreign bodies that has been missed elsewhere and then treated by us. So this is a 45-year-old female who has a history of injury to right lower lid while she was cutting bamboo. Initially, there is slight oozing of the blood from the wound, which healed in about 2 days. After 2 weeks, she noticed right lower lid edema and pus discharge from the wound. Patient consulted at an eye hospital elsewhere, where there is a history of surgical intervention without any improvement. She noticed progressive diminution of vision and restriction of ocular movement. The patient consulted us around 7 months after the injury. Visual acuity in the right eye was 20 by 400. A proptosis of 2 mm with infranasal dystropia was present. Ocular movements were restricted both in up gaze and down gaze. An MRI was advised, in which we see a large linear foreign body in the inferior extracorneal space extending to the orbital apex. Elective removal of the foreign body was planned by infraorbitotomy, and we removed on explosion a bamboo piece of 4.4 centimeter in length. Now, this is a 40-year-old gentleman who had a history of road traffic accident while he was riding a two-wheeler. He came to us for left eye loss of vision with mild proptosis. Visual acuity in the left eye was no light perception. Patient has mild ptosis and mild proptosis, and there's supralateral displacement of the globe. No wound of entry is seen in ocular or periocular area. However, on closer look, a healed scar is seen at the nasolabial fold. CT scan was done, and we found a linear metallic foreign body in the intracorneal space in the left orbit, which was orbiting the medial rectus medially in front and optic nerve laterally. And part of the foreign body is also on the anterior surface of the maxilla. Again, removal of the foreign body was planned by infraorbitotomy, and we removed a metallic clip of the pen cap of the size of 4 centimeters. Post-operatively, patient improved clinically with decrease in ptosis, proptosis, ocular inflammation. However, vision was not improved due to irreversible damage to the optic nerve. Now, this is a 9-year-old child who presented with swelling in the supranasal quadrant. There is a history of dacoity in his village home. Initially, he was treated elsewhere for the forehead and the brow wound. On examination, there is a palpable hard immobile swelling was present in supranasal quadrant, and globe was displaced infranasally. On CT scan, we found again a metallic density foreign body in the superior extracorneal space, which was traversing the orbit from supromedial to supralateral area. This direction is upwards towards the roof, causing the comminuted fracture of the roof. However, it is not involving the globe, and globe is spared, and patient vision is good. So again, we removed a bullet of 3.5 centimeter via anti-orbitotomy. This is a 20-year-old gentleman who works as an AC technician. He has a history of right eye loss of vision after blast of AC compressor. He came to us with a recurrent right eye lower lid abscess. CT scan shows 2 foreign bodies in the infotemporal quadrant of the orbit, which is surrounded by the granulation tissue. Inferior orbitotomy was planned, and we removed electrical copper wire along with the plastic covering from the orbit. So whenever we are suspecting intraorbital foreign body, non-contrast CT scan of the orbit and brain is the imaging of choice. If the CT scan is not present or in the absence of CT scan, plain X-ray can be used as a good screening tool to rule out metallic foreign body. MRI is reserved only for vegetative intraorbital foreign bodies, a small foreign body of less than 0.5 millimeters, or in case of negative CT scan. MRI is absolutely contraindicated when you are suspecting a metallic or ferromagnetic foreign body. So the management and extraction of orbital foreign bodies depends upon the type of the material used, size of the foreign body, location, associated morbidity and expertise of the surgeon. Small, inert, and deeply lodged metallic intraforeign bodies should be managed conservatively as they are well tolerated, if not removed. As most metals are inert, our serious complications can occur with certain metals like copper, iron, and lead. Complete surgical removal should be always attempted in cases of organic foreign bodies, as there is increased risk of infection and inflammation, as well as inorganic foreign bodies causing orbital complications. Now, this is a CT scan of a 10-year-old boy who came to us with a right eye gun palate injury. CT scan shows a small palate in the inferior orbit. On axial scan, we see it is inseparable from the infra-posterior aspect of the globe. So we plan a surgery via transconjunctival route. A canthotomy and cantholysis was done. Same as Dr. Manal told us. Then an incision is given around 2 to 3 meters below the tarsal plate. Dissection is done anterior to the orbital septum to reach the inferior orbital margin. Incision is given in the periosteum. Periosteum is dissected from the inferior orbital margin and floor to reach the inferior aspect of the globe. Incision is given in the periorbita to expose the foreign body. Foreign body is localized and removed safely. Now, post-operatively, patient did well. His vision is also improved from PL positive to 636. Now, this is another 60-year-old lady who had an injury with a date palm tree. On CT scan, we can see a linear dense foreign body which is present inferior and lateral to the globe, which is partially intracoronally and partially extracoronally in lying somewhere in the lateral inferior fornix. So surgery is again planned transconjunctivally via a different route. We give a conjunctival incision in the infratemporal quadrant. Further dissection is done towards the inferior fornix laterally to localize the foreign body by blunt and sharp dissection. Foreign body is localized and removed. We removed a 25 mm thorn is removed from the orbit. So our take-home message is clinical course of intraorbital foreign bodies are quite variable. High index of suspicion is required to make correct diagnosis so that we don't miss retained intraorbital foreign bodies. Thorough history and physical examination, including examination to look for wound of entry in ocular, periocular, and facial area is must. Diagnostic imaging is mandatory in all ocular and orbital trauma to rule out intraorbital foreign body as well as intraocular foreign body. Thank you very much for the patient care.
Thank you, Dr. Said, for enlightening us on management of orbital foreign bodies. Over to you.
Yeah. So now I invite our last speaker, but not the least, Dr. Farzad Pakdel. Dr. Farzad Pakdel completed his fellowship in ophthalmic, plastic, and reconstructive surgery from Iran University of Medical Sciences, occulofacial courses from Amsterdam, UCLA, and eye aesthetics from Los Angeles. Currently, he is the Vice Chair of Iran Research Association for Vision and Ophthalmology, Director of Plastic and Cosmetic Clinic, and Vice Chair of Education Department of Oculofacial Surgery for AB Hospital, Tehran University of Medical Sciences, Iran. He has spoken widely internationally. Dr. Farzad, please.
Thank you very much, Dr. Rizvi, for your kind invitation. It's an honor for me to join you in this wonderful meeting. Just make sure, am I audible and visible?
Yeah.
Perfect. So I will review the orbital decompression in thyroid eye disease. I will try to give some useful points to the colleagues. So I have no conflict of interest for any material or any drugs stated in this presentation. You know, with thyroid eye disease, we have expansion of the orbital soft tissues, and including muscle and fat and inflammation inside the orbit. So it causes some soft tissue changes like proptosis, restrictive myopathy, and compressive optic neuropathy, and eyelid swelling and changes over the eyelid like eyelid retraction. So we may see that we have 5 categories of manifestations of thyroid eye disease, including soft tissue involvement like injection and swelling, eyelid retraction, proptosis, optic neuropathy, and restrictive myopathy. So we can have some of combination of these 5 categories, not all of them. So let's discuss a bit on activity and severity. When somebody gets thyroid eye disease, the active inflammation causes progression of these symptoms and signs in the body in the orbit, like proptosis, eyelid retraction, and restrictive myopathy. So we pass through a 4-stage. The first step is the ascending phase. Then it gets to a plateau, then it stabilizes for a while, then it starts to calm down, then it stabilizes and burns out. So if we could actually start anti-inflammatory agents in the ascending phase, so we can decrease the chance for operation and less morbidity for the patients. When we want to do some corrective surgeries, we usually do it in the 4th stage when we have no further progression of disease. But still, we can have something like 15 to 20% recurrence after the 4th phase. There's an exception. We can operate, we do operate actually in the active phase, in the ascending and plateau phase. That's when we have vision-threatening problems. So the goals of treatment includes abating or controlling the active phase, as we discussed, and prevention of ocular and psychophysical damage. That's really important. We already shown that the quality of life in these patients is severely decreased. It's something like cancer. We redress ocular motor abnormalities, and finally, we improve the cosmetic disfigurements for these patients. So what's the role of surgery in these patients? Especially we are talking about the orbital decompression. Indications include this thyroid optic neuropathy for sure. That's actually can be seen about 5% of cases. Severe exposure keratopathy in global subluxation. These are actually the functional and vision-threatening problems. The other problems are static rehabilitation, decreasing congestive orbitopathy, restrictive strabismus, and some say it can help control of glaucoma. We can correct eyelid retraction. Even we are seeing patients that are actually cornea specialists and retinal specialists send us for severe intraorbital pressure before doing intraocular surgery. When we do orbital decompression, something happens. Not only we reduce the proptosis, the lid retraction, the lower lid, the upper lid, and also the puffiness and keratopathy decreases. We can stabilize the visual acuity in patients with DON. We can reduce the IOP. We can reduce the vitreous pressure, and sometimes we can reduce even diplopia. And unfortunately, sometimes we have even increase in diplopia. That's a serious problem we should deal with in the orbital decompression. So actually, there are numerous factors that can affect the decision-making on orbital decompression. And we should remember that the aim of orbital decompression is not just decreasing the proptosis. We can address many other problems for this patient. That's why nowadays we consider it like a customized orbital decompression, not simply to reduce the proptosis. And look at this panel of cases. We can see numerous reasons to do actually orbital decompressions in every patient, and we can address the other periocular problems at the same moment for these patients. So for customizing the orbital decompression, we should be aware if it's functional or cosmetic. We should regard other issues. We can see the long list here and even the ethnicity of the patient. There are many approaches. We can get access inside the orbit to do orbital decompression, like eyelid crease and lateral, stellar right, endoscopic, transcarancular, lower eyelid. So let's start with a case. This is a 65-year-old gentleman, diabetic, and he developed kind of the active disease, decrease in visual acuity, decrease the visual field. You can see we have apical crowding. You can see that the fat around the optic nerve in the apex is not visible in something like 120 degrees. So it's an indication for a DON, this thyroid optic neuropathy. So we started treatment, medical treatment first, and the visual acuity increased to 2/10 and 7/10. And then we continued with decompression. Another case that this gentleman showed decrease in visual acuity and did not respond to any medication. So we immediately start to do orbital decompression. When you have a patient with distal optic neuropathy, it's essential to remove the medial wall when we have the most effect on the optic nerve by the enlarged muscles. And it's important to remove this tiny bone here called strut. So for augmenting the effect of the decompressing in the apical area, I usually consider deep lateral at the same moment. So this is the post-decompression actually picture of the patient with increase in the visual acuity of the patient. So DON is a very important diagnosis for his patient, for any patient with thyroid eye disease. Actually, it's essential to look for DON even before the patient comes and say, I have decreased vision. It's usually seen in patients with active disease and soft tissue involvement like injections, lots of edema is not present in this patient. And usually the onset is not acute, it's just subacute or chronic. Remember that a normal best corrected visual acuity does not exclude distal optic neuropathy. We should take care of the patient with checking the color vision and the visual field perimetry and even CT scan if we are suspicious the DON. It's very interesting to note here, it's 70% bilateral. So in most of time you have no RAPD. Color vision defect is very important finding. We can see optic disc changes in like 30 to 40% of cases. So imaging is very important for confirming diagnosis and other things like contrast sensitivity and visual field and BEP as well. So remember, if we have three of actually these four criteria, we can say that the patient may have distal optic neuropathy, impaired visual acuity, color vision defect, APD, and abnormal perimetry. So look at here, I want to show you that this is the apical choroiding. You can see the effacement. It means that the extraocular muscles are touching the optic nerve in the orbital apex more than 90 degrees. No single test can establish or exclude the diagnosis of optic neuropathy in a patient with TED. And the most specific signs are color vision defect and disc swelling. This is why we always ask the colleagues to check these items all for in a patient you are suspicious or expecting to develop distal optic neuropathy. So just remember, these are the risk factors. Whenever you have these risk factors in a patient, you should very actively look for DON. Male patient, usually old age, and diabetes mellitus and smokers. Sorry. So when you want to address the proptosis and considering orbital decompression, it's a very old but actually a very useful classification to say it's a lipogenic variant, like this patient that we have mainly increase in the orbital fat tissue, minimal extraocular motility deficits and no diplopia for his patients, minimal congestive effects. And the other type is muscle variant. We have enlarged muscles and we have diplopia. We have distal optic neuropathy more common than the previous actual category. And some of these patients may have both lipogenic and muscle variant. So we can approach the orbit from different ways. And look at here, when we want to decrease the proptosis, we consider it. If we want to do like orbital fat decompression, it's usually considered the first wall. Actually, it's not a wall, but when we remove the orbital fat, the actually globular sits. So some say it's a first wall. And then we go for the lateral and medial, and finally we consider orbital floor. Nowadays, we consider less and less to do orbital floor decompression because of the increased risk of diplopia after the decompression. This is a transcarancular medial wall decompression. It's a very quick and very efficient. I usually say to my followers, it's like a phaco in cataract surgeons. It's actually, we approach to the medial wall and we remove the ethmoid sinus, and in patients with DON, remove the bone struts. We can approach toward the medial wall from this same incision if we need. If we want to remove the medial wall, one other approach is transnasal endoscopic approach. It's another actually very good approach with minimal actually swelling after the operation. Again, if we have DON or we have severe proptosis, we can remove the strut. Otherwise, I do not like to remove the strut because it increases the risk of diplopia of the patient. So there is another term called balanced decompression. It means we remove both medial and lateral walls. So the chance for diplopia is minimal in this subset of patients that undergo balanced decompression. So when we want to aim reducing the proptosis in a patient, we consider is a type 1 lipogenic or muscle variant. In this young lady, it's a lipogenic one. So I decided to do the first wall, the actually fat removal, and the transcarancular medial wall. Why? Because look at here. If you look at here, we have telecanthus in the left side because of the swelling of the actually the enlargement of the medial rectus muscle. So I decided to do transcarancular medial decompression to address the telecanthus for this young lady. So I could correct the telecanthus by that actually customized decompression for this lady. So what does it mean, deep lateral orbital decompression? We do not remove the orbital rim. We address the actually sphenoid bone. We have 3 major parts we should consider. It's door jam, the basin, the inferior part, and actually it's the lacrimal keyhole in the blue in the top. So it's very effective decompressive effect. We approach through the lateral canthotomy. I usually preserve the lateral canthal raphe to actually reduce the morbidity and lateral canthal deformities and edema at the site. It actually remove the sphenoid bone and marrow. And I usually do not remove the basin unless I need to remove the basin to decrease the volume in the floor. Otherwise, you may have descent and hypoglobus for a patient. So this is a quick video just showing what does it mean, deep lateral. So exposing the rim, diving inside the orbit, exposing the bony orbit. So, okay, yeah, we are doing removing the door jam here. You may see I reached the marrow. That's bleeding is coming from the marrow of the sphenoid. I usually started like from inferior to superior, like a U shape. So we start from the inferior orbital fissure toward the superior orbital fissure, and then removing the marrow, but preserving the part of the outer table. And sometimes even we need to actually expose the dura. It's not a big deal. So in patients with a mixed type, both muscular and fat, and the lipogenic variant, it's a good idea to remove the orbital fat if there's excess fat and do a deep lateral decompression. So it has decreased a chance for post-operative new onset or exacerbation of the pre-existing diplopia for these patients, and very effective in reducing the proptosis in these patients. So if in this, like in this gentleman, we remove the orbital floor, what happens, especially if you remove the strut, the patient develops hypoglobus and high chance for diplopia after operation. This is pre and post-op of this gentleman. So remember, if you have no lower eyelid retraction, it's essential to preserve the basin or preserving the orbital floor. Otherwise, you have asymmetry in the eyelid position and hypoglobus of the patient. Sorry, it jumped. So sometimes we need to do something like this. This lady has been operated by other colleagues, referred to me because the lady still had decreased vision, and the distal optic neuropathy did not show improvement after the previous decompressions on the lateral and medial wall. The patient had visual acuity of 2 meter FC in the right and 2/10 in the left. And look at here, we have already done something with the medial walls, lateral, just minimal touch and the inflow flow. In this subset of patients, because the anatomy inside the orbit it's sometimes very much confusing. So nowadays I prefer to do a computer-assisted surgery using navigation systems. So especially in these patients that have already done some unknown procedures, I know what I'm doing for the medial wall. I can preserve the lamina creeprosa, decreasing chance for CSF leakage, and effectively addressing the actually posterior orbitals strut. So this is computer-assisted deep lateral orbital for lady, and we had the chance to increase the visual acuity to 1/10. And the patient had regressed diabetic retinopathy, and it showed that this is the potential vision of the patient. So the last topic for me is something I want to say, maybe a pharmacologic decompression. I'm not sure if it's correct at the moment, but I hope so. Just a couple of months ago, in January 2020, FDA approved teprotumumab for treatment in active thyroid eye disease. Now we have two major RCTs showing that teprotumumab could decrease the proptosis in the patient. So it's very promising that it can do something like pharmacologic decompression in the patients. How does it work? Teprotumumab actually is a humanized monoclonal antibody against insulin-like growth factor. Now look at here. It can block the cascade that results in hyaluronate and other glycosaminoglycan secretion by the fibroblasts and decreases the chance of the inflammation of the patient. So we have less orbital inflammation and less adipogenesis for the patient, hopefully. So always we should remember orbital decompression is a major surgery. Even though we have actually doing a quick job here, I usually say to my fellows and my colleagues, always consider orbital decompression a major operation. We can have serious neurologic problems like CSF leakage and more than that, intracranial hemorrhage and even death. I have seen one case by one of the colleagues that was consulted with me. The patient developed ICH after doing endoscopic orbital decompression. It was a very devastating case, actually. It can result in visual loss by different mechanisms, can be complicated with orbital hemorrhage, and more, it can be complicated if you do a very aggressive surgery, removing lots of fat, removing lots of bone. You may develop high enophthalmos, and sometimes you remove the floor, you may develop hypoglobus. One of the concerned issues in orbital decompression is de novo, or exacerbation of the pre-existing diplopia. It's minimal for balanced decompression and fat decompression, as you may see here, and it's the highest risk for transantral, especially for Agora technique, that has been reported something like 20 to 60%. Although, in different schools in the world, some very good colleagues still doing the floor and transantral decompressions. And I saw a report just a couple of months ago by one of good colleagues in actually Los Angeles, not UCLA, in Los Angeles, that have just about 5% diplopia in these patients. So very common thing that I usually see in the hand of my colleagues is the post-decompression sinusitis. What it happens? It shouldn't happen actually, because orbitomeatal ostium is obstructed by the orbital fat inside the sinus, or damaged when you remove the floor by your instrument. So you should take care of the OMCD and actually delineate it before the surgery and start doing osteotomy posterior to OMCD. And yeah, this is the case I told you, intracranial hemorrhage after orbital decompression. Unfortunately, the patient succumbed after that thing. Thank you very much for your attention.
Wonderful talk, Dr. Farzad. You have covered all the part of the thyroid IDZ decompression.
My
Short
pleasure.
talk. Thank
you.
for that. Do you have any experience in the tempromab? I just recently came to know about this medicine also.
Actually, you know that teprotumumab is now available in the States, and but I talked just last week to the company, and fortunately we can have it soon in the region. But at the moment they deliver it for commercial usage for ordinary patients, not research patients, just in the States.
Yeah, that is true. Dr. Milind, you have any queries, any questions that come up you can ask?
No, in the chat box, there are no questions or no queries. So I think we have come to the end of the session.
Okay.
I really thank all the panelists for the wonderful presentations, and we look forward to see you again in Muscat Ophthalmology Society. Over to you, Dr. Said.
I also like to thank all the esteemed panelists for the participation and making this Oculoplasty session a great success. However, we do miss you all meeting in person. Maybe next year, inshallah, I'll meet you. Thank you once again for such excellent and informative talks and making us more knowledgeable. Thank you.
Thank you all.
Thank you.
It was a pleasure.
Thank you.
Thank you all. Bye-bye.